All right, I'd like to welcome everybody to this segment for Advocacy in Action here with Heart Rhythm TV. I'm Ambrose Panico, and I have the pleasure to introduce Dr. Chris Liu, who's joining us tonight. For those who don't know Dr. Liu's a practicing full-time electrophysiologist with Weill Cornell Medicine Medical College in New York City. He's medical director of the EP services for New York Presbyterian, Weill Cornell Network Hospitals. He serves on HRS's primary advisor on the AMA CPT Advisory Committee and as chair of HRS's Health Policy and Regulatory Affairs Committee. And in his free time, which doesn't exist, he also gets to take care of patients. So, Dr. Liu, thank you for joining us tonight. To kind of
Thanks, Ambrose.
set the precedence for what we're going to talk about, a lot of changes, healthcare policy changes this year. So we do want to highlight some of the stuff for our viewers, the real important facts, and no one better than you to help us out with that. So
Thanks, Ambrose. It's a pleasure to be here.
just to bring everybody up to speed a little bit, on November 1st, 2024, CMS published the final rules for a couple of things for calendar year 25, both for Medicare physician fee schedule, hospital outpatient prospective payment systems, and ASC payment systems. The latter of which we're actually going to have a whole nother segment with Dr. Liu, myself, Dr. Ken Enbogue, and a couple others to go into deeper detail as well. Policy changes in both the rules will be effective January 1st, 2025. And so we're going to try to highlight some, but not all of the provisions and quality program changes that will be relevant to our EP team and more importantly to their patients. So Dr. Liu, what would you say is the most significant changes physicians should expect for calendar year 25 from CMS?
Okay, well, Ambrose, just to start off, I'd actually like to just say that, of course, every year CMS makes a rule for the following year, the calendar year that starts in January. And, unfortunately, we EPs in prior years were not paying so much attention until more recent years when the ablation cuts really happened dramatically a couple of years ago. And so, this is one area that the health policy team at HRS has really wanted to bring more emphasis and bring more spotlight to this over time, is to really help our members, help EPs and everyone else in our field to really understand that this is an ongoing process. It's a marathon, not a sprint. And every year there are going to be adjustments. And we as healthcare providers have to follow along with what's happening in regulatory affairs in the government with payers so that we know what's happening. We know how to plan ahead. We know how to roll with the punches, if you will, and where to place our attention in terms of advocacy. And we'll get to that, I know a little bit later in the conversation. So, as is often the case with these final rules, and as we physicians, unfortunately, have really gotten used to, every year there's some sort of, a threatened or real cut in physician payment across the board from CMS. And so this year, unfortunately, is no different. So just in terms of universal physician payment, CMS finalized a conversion factor of $32.34 and change for each work RVU, which is a decrease of about 2.8%, 2.83% to be precise, from the conversion factor for 2024. So that means that every physician and healthcare provider billed service using RVUs is going to get 2.83% cut in revenue and payment. So this is due to a combination of factors. There is a kind of a budget neutrality adjustment that's 0.02%. There's a couple of other factors associated with MACRA. And most importantly, from 2024, if our members might recall, we had fought for a payment increase because the same type of cut was threatened for 2024. And thanks to advocacy from all physicians across the board, there was a 2.93% payment increase for services that was finally issued by Congress in March. And so that unfortunately expires at the end of this year. And with the expiration of that, then there is this conversion factor change that will then, potentially cause a cut across the board for the conversion factor due to this final rule.
Okay, great. Thank you. Now, Dr. Liu, what do you think the perceived impact of these cuts is going to be, or should we expect?
Well, so, you know, um, Ambrose, 2.8% seems like maybe it's a small number. But obviously, if you add that up for every patient service that we provide to every patient in our practice and in our groups and in our institutions, that's going to add up. And so, we know, and the American Medical Association and all the, medical physician practices know that Medicare physician payments have significantly declined. And the numbers are essentially that physician payments for Medicare have declined 29% from 2001 to 2024 when this is adjusted for inflation and practice costs. Think about that, 29%. Okay, so not only have we not had pay raise for inflation, we've had cuts. And so, of course, as practices struggle to survive with rising labor costs and other costs associated with practice, the practice of medicine, and just bringing patients in and to even have facilities to see and care for patients, this has already dramatically affected patient care. And, we know from surveys and anecdotally that physicians have increasingly experienced burnout due to the need to see more patients. There are now access barriers because practices, private practices especially, have closed across the United States, especially in difficult rural areas where patient access was already a problem. And there are increases in layoffs, reduced services, office closures, physicians obviously choosing to leave clinical medicine. And so we are already seeing access issues in electrophysiology, especially because we're already a very small group of board certified electrophysiologists in the United States to be able to provide for, an actually increasing need for arrhythmia care services across the board. So it's really going to be a dilemma. And, I think the population and the society is going to see this, as arrhythmia care comes more into the spotlight.
Yeah, I couldn't agree more and very well put. So we've kind of gone over the impact of what the conversion factor changes could be. And I know I would be remiss not to ask, but our members and our viewers certainly want to know what is HRS and what has HRS been doing about this and continued plans for what they plan to do.
Yeah, so as you can imagine, Ambrose, this is an issue that again affects every physician and every healthcare provider who gets paid by the RVU system. So this is not just an EP issue. This is, the conversion factor is a universal physician issue. And so this is why the AMA and other medical societies and HRS has been a significant member of that group of medical societies. So there is a pending act in Congress. So HRS, we have sent out to membership notification about this. So this is HR 10073 for those of you who have not checked your emails or other social media messages. So this is the Medicare Patient Access and Practice Stabilization Act. Okay, it is a bipartisan act, and it is part of the final year-end package that is currently being considered. And so in the past couple of months, we've sent out multiple messages through our membership to try to get people to reach out to their members of Congress and lobby and advocate and push for this act to be passed. And so this act would institute a 3.6% rise in practice expense, as well as eliminate the 2.8% payment cut that was enacted by CMS. And so in addition to that, there would be potentially a 1.8% payment update that is calculated based on half of the Medicare Economic Index. Okay, so I think we're not being greedy by asking for half of the Medicare Economic Index in terms of accounting for inflation for a 1.8% payment rise. And so this is an act that we really strongly push for and advocate for, and we really still want our membership to reach out to their members of Congress and get their members of Congress to act on this. So in addition to lobbying for Congress, as you and I'm sure others have heard, HRS, and really in order to better do this in a sustained effort, has recently formed Heart Rhythm Advocates. And so this is the new advocacy organization that is going to, take donations and really use all the wherewithal, all the different tools and strategies to get payers, Medicare, the government to pay attention to electrophysiology services and understand the importance of these services and the accessibility of these services to patients around the United States. And so certainly there's going to be a lot to come. And, certainly in our health policy team, we're very excited about this. We will still continue to do the health policy work at HRS, but Heart Rhythm Advocates will help with a lot of the strategic and lobbying efforts on our behalf. And so, for example, one of the things is that HRA is going to plan to do a fly-in of members to visit congressional offices, and so this is something that is really long overdue, and so we're really looking forward to initiatives like this moving forward.
Fantastic. I think we all have seen and experienced some of the impact of previous CMS cuts. And as you've highlighted a number of those projected for 2025, one of the concerns that a lot of healthcare systems will have is, of course, workforce utilization, telehealth, virtual visits, really grown and born in the pandemic, but have become a tremendous valuable option for a number of practices, including my own, to use, and at least in my experience, unanimously loved by our patients. There's some changes there as well. Can you shed some insight for our viewers on that?
Yes. So this is, as you said, Ambrose, this is something that our patients and providers have really grown accustomed to using, especially for people who live far away geographically from their physicians and practice clinics. And so unfortunately, this was a temporary measure for patients to be able to use video and telehealth services essentially as if they were in-person visits. It was a temporary measure instituted during the COVID public health emergency for patients to be able to use these services from home. So these telehealth services were originally designed for patients to use them from so-called origination facilities. So they had to be at a healthcare facility in order to use these healthcare telehealth services. During the COVID pandemic, CMS created a temporary exception to allow patients to use these telehealth services from home and for us to bill them and get paid as if they were in-person visits. So that is still set to expire at the end of this year, 2024. And therefore, starting in January 1, 2025, unless there's some congressional act or unless there's some change of heart at CMS, they have reiterated, CMS has, that the only services that patients can have telehealth services from home will be certain behavioral health services. And so regular medical services like EP services, seeing their physicians and discussing, issues over telehealth will no longer be covered, like in-person visits. Certainly, you can see the rationale that this type of thing could be subject to abuse, but certainly many of our patients in electrophysiology have really made very appropriate and excellent use of these services in order to have better access to care, and frankly probably to keep them out of healthcare facilities like emergency departments. So this is unfortunate. We have really in our comment letters to CMS and in our other advocacy efforts to the government, we have reiterated this point over and over, and this is something that they have finalized. And so this is something that we have broadcast to the EP community, that there needs to be recognition of this, and that practices, institutions will need to reconcile this in terms of how they plan and can see patients moving forward, and certainly to plan for their revenue cycle appropriately.
Yeah, and again, I think this highlights it's not just an EP specific problem. This is a healthcare as a community problem, because it's been utilized across the board. And if you go to any of Dr. Singh's talks about the future of healthcare and AI and sensors, he's a big advocate that this is going to be a big part of where we are in the future. So it'll be interesting to see, after January 1, what we can do there. There have also been some changes to the 90-day global surgery and transfer of care rules. Would you be able to explain these changes and how it may impact our members and viewers?
Sure. Ambrose, this is, we sent this also including this point in the broadcast to membership about the final rule. And, this is a bit of a subtle point. So probably not a huge deal to most of our members. So essentially, some of our EP services, including most importantly the device implant procedures, have a 90-day global period. That means during that 90-day global period, for us to see the patients for follow-up, wound checks, and other care as it relates to the device that was implanted, that's all included in the 90-day global period. And so there are certain circumstances where the operating physician, so therefore let's say the implanting electrophysiologist, may not be the same person or even in the same practice who it subsequently does the follow-ups. And so let's say a patient is referred to you to implant a pacemaker, Ambrose, and then after the pacemaker implant, let's say the person comes from 3 hours away, and so they're just going to follow up with their local doctor for the post-operative wound care and the pacemaker follow-up, and their cardiologist office can manage that. Then that separate physician is going to be able to now bill separately for that post-operative care visit. And so then there's just this point that then you would put in a specific modifier, I think it's modifier 54, if you are just the operating physician and you do not plan to do the post-operative care. And then the separate physician would be able to then bill for that post-operative visit. This does mean a small reduction in the RVUs for you as the operating physician, and the then post-operative physician who is seeing the patient in follow-up would get a small, RVU, and so I think it's under 1 RVU. It's something like 0.16 or something like that. So it's a very small RVU, but it does create a mechanism for separate physicians to care for these patients.
Great, thank you. Now, there was one positive EP-specific change to merit-based incentive payment system, or MIPS, and that was Quality Measure 393. Can you expand upon this approval and what it means for our viewers and members?
Sure, yeah. So, it's always so hard to keep track of all of these instead of merit-based incentive payment systems, or the MIPS. So CMS did finalize some changes that are reasonably substantive to this quality metric, which is infection within 180 days of cardiac implantable electronic device implantation, replacement, or revision. So so HRS supported the changes to clarify that a new device, okay, would include either the first device or a device implanted with new functionality. And so this just does give us a little more flexibility in terms of defining what is a new device. And so any device that is upgraded or exchanged that has new functionality it would be then classified as a new device. So it's a small point, but it can affect some of our members in terms of quality metrics.
All right. And then I think our final question for this session would be, with the recent election behind us and the next Trump administration taking over in January, what should we expect going forward?
Well, so, Ambrose, I think this is definitely a hot topic in the media and everywhere else. And, certainly, I think healthcare and electrophysiology is going to be, part of all of that conversation. And so, as you probably have heard, some of these proposed Trump administration appointees to the HHS position, the FDA position, the CMS positions, are talking, pretty aggressively about cost containment, cost reduction measures. And so I think, everyone in healthcare is kind of holding our breath a little bit about, what exactly this means. And so certainly at HRS, we're keeping a close eye on these factors and what these people are saying, as well as, their history of what they've done. So in terms of just our philosophy, I think we're going to be patient and we're hoping that we will be resilient. I mean, just like all of our members are, we're here for a good purpose. We're here to help our patients. We know that arrhythmias are a huge public health and health policy issue for many, many patients and people in the United States and around the world. And so these are real medical issues that affect people's lives, and we are here to help them. And so we just need to speak up for what we stand for, what we do, and what we do for our patients. And so I think with that in mind, we're going to be, again, cautious because certainly as we learned for the ablation cuts, we really want to stay out of the spotlight for CMS as much as possible. But at the same time, we need to advocate for, what our patients need and what our practices need to remain sustainable. So stay tuned. We have another session that we will talk about the ASC question. And of course, CMS did not include EP ablation procedures in the ASC covered procedures list. And so this is one area that we're actually going to kind of think a little bit ahead about in terms of what this is going to mean for our strategy next year and going forward, how we're going to advocate for that, and what ways we should advocate for it. And some of this is going to, I think, depend on where this administration is going to go in terms of, how they look at payment for facilities and physician services.
Very good. Well, Chris, thank you so much for joining me. Really appreciate the conversation and applaud your and the society's efforts as far as what we've been trying to do, what we plan to do, and really taking a more proactive role moving forward for advocacy. So thank you.
My pleasure, Ambrose. I think, the more I've participated in health policy work at HRS, the more I realize that most of our members really care so much about what we do. And like I've said to many people, I think we've been very fortunate in EP to have done well over the years for ourselves, for our practices, and most importantly for our patients. And we just need to understand the mechanisms that we're working with so that we can navigate it smartly and just as importantly, I think patiently over time.
Yeah, I think that the future here is definitely that intersection where we all come together and figure out how we can provide high quality, cost effective, and timely or efficient care to our patients to ultimately help the system contain costs and provide the best, arrhythmia care that we can for people. So,
That's so right.
yeah. With that being said, I'd like to say thank you again for joining us. I'm Ambrose Panico. This is HRS TV. You can find more content on our YouTube channel, and please don't forget to like us and follow us on social media.